on the course information page. Okay. I'll put somebody in here. Okay. So we're going to go through that. I've inserted some strips so you guys can see some examples after we go through, like, what is the definition of a particular dysrhythmia. So that hopefully will be helpful to you, as well as a few other things. As Jane and Janie said earlier today, we don't, this is not an anatomy class. So I'm going to just touch on a couple of things just to try and hopefully refresh that anatomy physiology that you had, but we're not spending a lot of time on it because that's something that you already should come into this course with an understanding of. But just for the sake of talking about some of these things, I'm just going to touch on it very briefly here in the very beginning. I have a few pictures to go along with that as well. But we're going to move pretty quickly and try and get through the basics today and get you out on time, hopefully at 10 minutes to 2. We will take a little break at 10 minutes to 1. And then tomorrow we're back at it at 9 o'clock. And we'll do that in the morning session and then again in the afternoon session, okay? It's very important that you understand EKGs and the flow of the blood through the heart, because then later in the semester, as you get into Dr. Benetti's cardiac lectures, you have a lot of cardiac lectures toward the end of the semester. This is going to just help you understand all of that a little bit better. And so we're going to, spend some time on this. But again, a lot of it here in the very beginning is going to move quickly just because it's not an anatomy class. We're going to just touch on it. So, okay. I think the waiting room is empty as of now. So here we go. Sorry, I have a frog. I'm going to have to keep drinking water. I'm not going to read you the objectives. Let me share my screen here. And here we go. Come on. Share. Here we go. I'm not going to read you the objectives. I think you guys can read that on your own. But again, we're going to touch on some of these same things. Actually, in your codes lecture here coming up in just a couple of weeks, I'll be teaching that as well. And then this is also going to help as a foundation, especially when it comes to the blood flow and how the heart, could be affected by different disease processes. It will help when you get into Dr. Benetti's cardiac lecture. So let me see here if I need to make this so I can see. Anybody pops up in the waiting room. Okay. So we're going to dive right into it here. So your heart, we should all know this by now, muscular organ sits in your chest. It does not sit straight up and down. It sits on an angle. Your atria are going to lie more toward the sternum, toward the right of the chest, and your ventricles are going to lie toward the left. Remember, the bottom tip of that the bottom tip of the heart there is called the apex. You guys should be familiar with that. Way back to 101, where you took the apical pulse more toward that bottom left side. So our ventricles are going to sit down there, and the apex is going to be at that bottom tip there. The heart essentially is 2 pumps, and each pump is divided into 2 chambers. Each pump has an atria and a ventricle. Remember, there's that atrial and ventricular septum. You guys probably touched on that in pediatrics when you talked about little kiddos that were born with maybe a hole in their heart and that ventral septal defect, they would have referred to it as. So it's 2 pumps. Each pump has 2 chambers. The major function of the heart is to circulate blood. I want you to think about this. Sometimes you have a patient and you're looking at their pulse oximetry and it's like 88, 89, or maybe even lower, and you're like, oh gosh, I don't like this. It makes me nervous, because we always like people to be 92 or higher, right? That's what all of our doctor orders always say. They say, give oxygen, 2 liters per minute by nasal cannula to keep the oxygen saturation above 92%. Well, there's a reason, and we'll get into that later, like into respiratory, and we'll touch on it simulation too, about why that magic 92%. But anyhow, the major function of the heart is to circulate blood. So when I see my patient and they've got a pulse oximetry reading of, let's say, 87, 86, 89, and I give them oxygen and my number doesn't change, well, Your heart is the pump. It is responsible for the perfusion. So if the pump is not working correctly, you can give that patient all the oxygen you want, and it's not going to make a bit of difference. The heart has to circulate the blood that has the oxygen in it. So if there's a problem with the pump, that oxygen reading is not going to change. So keep that in mind. Sometimes we just think, oh, let's just put oxygen on them. And sometimes, depending what the problem is, maybe it works. But if the problem is with the pump, which is our heart, it's not going to make a difference. Okay? All right, so here's one of those pictures I told you I just wanted to insert real quick. This is not an anatomy class, but just for, we all learn a little differently. Some people learn by visual, some people are oracle learners, some people are tactile learners. So if this helps you, that's great. Here's that apex. I don't know if you guys can see that or not. At the very bottom. And it's important for you to know and understand the pathway of blood. And I have a little bit of a better picture here in a minute that's going to help you with that. Just a cross section so you can see inside. Remember there on the patient's right side of the heart, when the blood moves from the right atrium to the right ventricle, it has to go through that tricuspid valve. And on the left side, it has to go through that mitral valve. And then you see how the right atrium receives the blood. The venous return goes to the right atrium, and then we ship it back out to the lungs to get oxygenated, and then it comes back into the left atrium, and then from the left ventricle out to the body. Okay, we talked about this already. The right heart pumps the blood. The pulmonic circulation, left pumps it to the body. It contracts and relaxes. It has mechanical and electrical activity. Okay, the heart really can't function one without the other. This is the directional flow that I was talking about just a minute ago. It's important for you to understand this flow of blood, how it comes in, okay, from the venous return into the right atrium through the tricuspid valve to the right ventricle, out to the lungs, back into the left atrium to the left ventricle, and then back out to the body. If you get confused about the flow, the directional flow of blood, think about a single drop of blood if you have to, okay? It's important. It's so important. When Dr. Benetti gets into all these cardiac issues toward the end of this 7 weeks, if you do not understand the directional flow of blood, you're going to have a difficult time understanding the concepts and what's going on with your patient when the pump is not doing what it needs to do to get that blood going in the right direction. Okay? Okay, here we go. Mechanical power, you see there, comes from muscular contractions. We know that as diastole and systole. And you can read the rest of your slide there. I'm not going to read it to you. I remember this because I think about diastole, the blood is going down, DD. You remember it however it works for you. But in diastole, the ventricles receive the blood from the atria, okay? So that blood is going down. And then when we think about systole, that's the contraction of the ventricles that sends the blood out. So I think about D, the blood is going down, systole, S, and it's sending it out. That's what makes sense to me. If that helps you, that's fantastic. But that is the mechanical activity of the heart. Now, the pressure in the chambers is going to rise during systole, okay? That's important. Now we have electrical activity of the heart as well. Again, this should be reviewed from anatomy, so we're not spending a lot of time on it. But the cardiac cells and muscles, they generate their own electrical activity. That is what's known as the automaticity. That's important to know. That is something special about the cardiac muscles. They are able to generate their own electrical activity. Okay? Now, when we look at an EKG, the electrical activity, the EKG shows us the action potential that's produced by the cells of the myocardium. Okay, again, this should be reviewed from your anatomy physiology, but it's important that you understand that. Okay, continuing on with electrical activity of the heart. Again, we already talked about in mechanical, we have diastole and systole. In electrical activity, we have depolarization and repolarization. So what's going on there is it's happening because of the cellular shift of the negative and the positive ions, okay? The depolarization is going to be the contraction of the heart. And the repolarization is when it's just an ever so brief moment where the heart is resting, it's recovering, it's getting ready for the next contraction. Okay? And we'll talk about that when we look at the EKG strip and specifically talk about what's happening where. And if you watched your 4 videos like you should have watched before this lecture today, some of this should already be making sense. All right. So at rest, potassium's in greater amounts intracellularly and calcium and sodium greater amounts extracellularly. So what's happening is there's this movement of potassium and calcium and sodium when the heart is electrically stimulated. So everything starts shifting around. All right, and then further into depolarization and repolarization here. So depolarization, you see here the active electrical phase associated with systole. So depolarization, the electrical component, must take place before the heart can contract or pump blood, which is in mechanical known as systole. Okay? Then toward the end of depolarization, the sodium is going to stop shifting. Okay? The sodium and potassium, they're going to return to their proper places. And then that's going to allow for our rest or recovery state that we know as repolarization. And then it's going to wait for the next depolarization to happen. Okay? Now, we have what we talk about in our heart as an absolute refractory period and a relative refractory period. We're going to discuss more of this when we get into codes and also into simulation when we talk about cardioversion and defibrillation. But in absolute, the cells don't respond to stimulus. Okay? Absolute is when cells have depolarized and they're starting to repolarize. No impulse can be conducted to cause a contraction. So in absolute, the cells don't respond to the stimulus. I'll try to pause every so often, so if you're taking notes or something to supplement your slides, then you have a minute. I do tend to talk fast. If I need to slow down, please don't hesitate to tell me. I will not be offended by that at all. I've always talked fast and walked fast. Okay, so we have the electrical conduction components, the SA node, which is our heart's pacemaker, the AV node, and then the ventricular system that is the hinge Purkinje systems. And it's made up of the bundle of His, the right and left bundle branches, and the Purkinje fibers. This should sound like everything you learned in anatomy, whether you took it, you know, at the beginning of this program or 5 years ago. You should know that. Now, our SA node is going to give us a pulse rate of about 60 to 100. But the AV node really is going to slow things down to about 40 to 60. The reason that the AV node slows the impulse down is because we want to allow time for the ventricles to fill. Okay? And then the Purkinje fibers down and that wrap around like fingers up around, they come down between the ventricles and wrap up around the sides of the ventricular tissue. Those actually can end up giving us a pulse of like 20 to 40. And when we start talking about blocks, that's going to make a little more sense. Okay? But again, just a quick anatomy physiology review here. Okay, as I said, the SA node is the heart's pacemaker. It initiates 60 to 100 beats a minute, hopefully. That's normal, okay? Located at the top of the right atria where the superior vena cava joins the atrial tissue mass. It's right at the very top, okay? The normal heartbeat begins in the SA node. That is normal. That's where it begins, okay? Depolarization and simultaneous contraction of the atria cause the P wave, okay? And systole, again, it's known as systole in the mechanical component. All right, the AV node, which is located in the lower right atrium, more toward the bottom of that, Okay, it intentionally delays the impulse again to allow time for the blood to move from the atria to the ventricles so they are nice and full. Okay, the AV node sits like on that floor, just right above the ventricles, but it's, you know, right there at the bottom, the floor of the atria. And it's delayed is intentional. It is going to act as a backup pacemaker. All right. Then we talked about the bundle of His. Again, if you think back to your anatomy lecture, it runs, you know, down through between the two ventricles from the two different pumps, the right and the left heart. It's going to run down through there. You're going to have the thick cords of fibers at the first 1/3 of the ventricular septum. Okay. Sometimes, again, that's called the common bundle or the AV bundle. You'll hear it referenced to a number of different things. Okay. But the His-Purkinje system, again, is the bundle of His, the bundle branches, and the Purkinje fibers. Hopefully this is sounding familiar. It's bringing all that A and P back. Okay. All right, so continuing with the electrical conduction components here, the Purkinje fibers and the His-Purkinje system. The contraction and depolarization of the ventricle sends blood out to the lungs to get oxygen, and then back to the heart, of course, and it also sends it out to the body. So the contraction or the depolarization of the ventricle is going to send it to one of two places, the lungs or the body. Okay. Now, if the Purkinje fibers are conducting the impulse, remember I talked about that was 20 to 40. If the Purkinje fibers are conducting the impulse, you'll see that the QRS complex becomes wide. And we'll see that again when we talk about blocks a little bit more. And we're going to talk about measurements, and so we're going to know what's normal and what's wide here in a few seconds. Okay, so EKGs, we can see them in a variety of different ways. The 12-lead EKG is used for diagnostic purposes. If anybody works in the ED, or maybe as a medic, or maybe has just had to, excuse me, had to go to the doctor for some reason or another, they will put 12 leads on you. So they go to your arms, they go to your legs, and of course, a whole bunch across your chest. So it is actually 12 wires, 12 leads, 12 different electrodes on the body. Now, there's also continuous cardiac monitoring that will give us an EKG strip. And if you work in the emergency department, a telemetry unit, an intensive care unit, any of you that were in clinical with me in 101, way back in 101, that were out at 3 Tower Pineville, our patients had, you know, 3 leads on them there. Everybody on that unit had to have a telemonitor on. So you might see a variety of things. But for diagnostic purposes, the 12 lead is the way to go. And when somebody comes into the ED with chest pain, the tech knows, hey, I've got 10 minutes to get a 12 lead EKG on this person and have the printout ready to go so the doctor can look at it. So again, that's 12 leads going to the arms, the legs, and all across the chest. But the EKG, really, we get that, you know, for diagnostic purposes, but really it's telling us what the action potential of those myocardial cells are. Okay, this is not too difficult here. Lead refers to the electrodes placed on the patient's skin to record the electrical activity. Something to keep in mind, if you have a man that has a really hairy chest, you need to have that hair removed where those electrodes are going to sit in order to get a good attachment. You are not going to have good representation about what's going on in their heart if it is just that sticky electrode is just kind of dangling off of the chest hair. So you'll have to use the, excuse me again, you'll have to use a little razor to remove hair in the places those electrodes are going to go so we get a really good attachment. All right. So I like this picture because I think it tells us a little bit better about what's really going on when we do an EKG. Now, you'll see that there's all these different pluses and minuses, and it's going through the heart different directions. I like to think about an EKG, and hopefully this doesn't confuse anyone, but I like to think about it kind of like an MRI. We know that an MRI takes a bunch of different slices, so it gives us a real clear look about what's going on with every single part of whatever body part is being examined. and then an MRI. Well, I like to think of an EKG kind of like an MRI for the heart. It is looking from all these different directions, downward, upward, across this way, straight down, straight up. It's looking from all these different ways. And what it's essentially doing is, if I were to stand up here in my room here, and I would have one of you stand to my right and face me, and one of you stand to my left and face me. Somebody's going to stand in front of me and face me. Somebody's going to stand behind me and face me. Okay? You're all going to see something a little bit different. That's what an MRI does when we're doing an MRI of like the brain, or of whatever, the abdomen or whatever. The same thing's happening with an EKG. It's looking at the heart from all these different directions, getting a little bit of a different perspective, a little bit of a different vantage point. So if whoever's standing to my right would look at me, they would say, okay, I can see that she has her hair tucked behind her ear, and if I pull that back, she has an earbud in, okay? And whoever's standing to my left is going to say, no, her hair's not tucked behind her ear. I can't really see anything. And whoever's standing behind me says, okay, she has long hair and it comes down to about the middle of her back. And whoever's standing in front of me says she doesn't have any makeup on, no glasses. That's all true. So you're all going to see something a little bit different. The person behind me is not going to see what my face looks like. The person that's looking at my face is not going to see what behind me looks like. So this is looking at the heart kind of that same way. It's getting a different perspective. And so then it's helping us to be able to diagnose or identify what's going on and with what part of the heart, where are we having an issue. So it's important that we get that 12-lead EKG when somebody comes in and says, hey, I'm having chest pain. We're going to get going on that. It's really important. Now, a lot of times you'll see on your monitor strips, no matter if it's in the ED or if it's in telemetry, ICU, a medic truck, a lot of times we look at lead 2. It tends to be the prettiest of all of them most times. The more, I guess, easier to identify what's going on outside of having a 12 lead. So a lot of times we'll look at lead 2, but not always. Not always. Okay. This is an example of a 12-lead EKG. I think probably most of you have seen these at some time or another, whether it was in clinical or maybe it's in your role as a tech or a medic, or maybe you've had one done. But essentially what's happening, if you look across the top of the paper, it says lead 1, lead AVR, lead V1, V4, excuse me, and then you see 4 more in the second and third row. So it's important that we have this for diagnostic purposes, because a doctor is going to look at several different leads off of the 12-lead EKG printout to make a diagnosis of whether they have a block, are they having a STEMI, are they having an NSTEMI. They're not going to look just at one lead alone and say, oh, there's an issue, okay? Now, what's not shown here on this picture is typically at the very bottom below those 3 rows, there is a 4th row. And that 4th row on that 12-lead EKG will be a full EKG strip, a 6-second strip at least. And it will give you a really good look at what the rate is, because from all these other little snippets, you see you just have a small little, 1.5, 2 inches wide. That's not really enough. That's not even 3 seconds. That's not 6 seconds. We can't determine what the rate is. So having that 4th row at the bottom of this, and typically it's set again on lead 2, it will give us a full, 6-second or maybe even longer picture of that one lead and help us to see what the rate is and if something is regular or irregular. And we're going to talk about that as we start talking about what steps are. Dr. Benetti mentioned that this morning. But you've got to have the 12-lead EKG to make a lot of diagnoses. Okay. Again, just another vantage point of what it might look like with the anatomical markings there from the ribs and the heart where you're placing these leads. Okay. Okay. So again, 5-lead or 3-lead. Most common leads there. You don't have to get too excited about this. But 6-second strips are run at the start, usually, of every shift, and specific hourly intervals and as needed if the patient starts to have a run of something ugly that scares us. There's a monitor tech on the tele units that is his or her sole job is to watch the monitor and be able to identify if something's going wrong, alert that nurse that's responsible for that patient's care. Your patient's having a run of VTAC, your patient's having, some PVCs or whatever's going on. But they watch those alarms, they're watching for dysrhythmias, and they're making the appropriate notifications. It's really important not to interrupt those people, not to distract them, because they might have, 30 different strips they're watching. Okay, and continuing on with the EKG, it's just a collection. It's paper that holds a collection of small squares, and small squares all sit inside larger boxes. We're going to look at that. One small square, you need to know this. You're going to see this again. One small square is 0.04 seconds. This is important. You need to know this because it's going to come into play when you have to calculate things. Okay? There are 5 small squares to each larger box. So if we take 5 times 0.04, that is 0.20. So therefore, each larger box with the dark bold lines between them, and I'm going to show that to you in a minute, is equal to 0.2 seconds. Again, you need to know this. You're going to have to use it to do some calculations. Okay? All right. This picture, I think it makes it a little bit clearer. So we see the first little bump is a nice rounded P wave. The next deflection and then upright and back down is our QRS complex. And then the last larger rounded wave is the T wave. But what I specifically want to point out on this really nice clear picture is everyone should be able to see that there are 5 little tiny boxes between each of the darker red bold lines. Is everybody able to see that? Okay. So 0.04 for each little box times 1, 2, 3, 4, 5 gives us each bigger box that's surrounded by 4 dark red bold lines would mean that across from left to right is 0.20. Does anyone not understand that? If so, unmute yourself and just tell me. Okay, fantastic. We're also going to talk about the voltage here in a minute, and that's what we're going to be talking about going up from bottom to top of this same box and how much each one of those measures. But right now, you need to understand each little tiny box or tiny square, 0.04, there are 5 of them across from bold line to bold line. So 0.04 times 5 is 0.20. Okay. All right. So that one didn't have it. So I'll show you a strip here in a minute. That particular one I just showed you did not have it. But there's going to be little slashes or hash marks at the top of the EKG strip. Okay? That's going to help you with the measurement. From one slash mark to the next slash mark is going to be 3 seconds. And from that slash mark to the next slash mark, and I'll show you again, is going to be another 3 seconds. So that will give you a 6-second strip. Okay? Now, keep in mind, if someone loads the paper into the printer for the EKG monitor upside down, your little slash marks might be at the bottom. It's still the correct measurement. It's just not where they're supposed to be. Okay? You still can measure off of that. Okay. Now, when we see this strip here in a minute that has the slash marks at the little top of the page, there is going to be 15 boxes between each slash or little hash mark. Okay? Oh, I got to put somebody in from the waiting room. Okay, sorry about that. Let me mark that down. Let's see. Okay, sorry about that. So that's going to be 15 boxes between each slash mark. We're going to look at it in a second. So you would take 15. We know that each of those bigger boxes, each of those bold lines, that's a box, is 0.20 times the 15. That gives us the 3 seconds. Okay? And this is what I was just explaining to you.
When you're saying there's 15 boxes, are you meaning like the big dark boxes, not the little
big
tiny
dark boxes, yes. Yep. So we have 5 little squares inside each one large box. And so with this, we would have 15 of those larger boxes between the first hash mark and the second hash mark at the top of the EKG strip. And I'll have a strip here in an example for a minute. We're going to go through all of this, so it's going to make sense. Okay? Good question, though.
Will they always be called squares and boxes?
I can't say always, but for testing purposes, it's going to be evident what we're asking you. Okay?
Okay.
It'll be evident. Okay? You're going to be able to figure that out. Okay. Now, I told you a minute ago we're going to talk about voltage. So not only having those 5 little boxes that move from left to right on our paper, the 5 little squares within the one bigger box, but we're also going to have those little squares within the bigger box that we're going to measure vertically, okay? And that's going to be considered our voltage, okay? So again, on the strip, when I show you this, it's going to make sense, but there's an imaginary line. We call it the isoelectric line. That's simply where we're saying that the voltage is at 0. One small vertical square is going to be 0.1 millivolt. And again, that bigger box had 5 squares from left to right, but it also had 5 squares from bottom to top. So if it's 0.1 millivolt times the 5 little squares inside that box, it's going to be 0.5 millivolt. Okay? And here's the picture I was talking about. I really wanted to show you. So okay. Everybody see the bolded box? Okay. So this picture is very clear. Everybody should be able to count. Doesn't matter which one you're looking at, but just pick one of those big bolded blocks. And you should be able to count 5 little squares within those bolded walls from left to right. Okay? If each one of the little squares from left to right is 0.04 times 5 from bold line to bold line of the bigger box, then that gives us 0.20. That's how we're measuring our time. Within those same bolded edges of that bigger box, if you look from bottom to top, we're measuring our voltage. How strong is it? Each one of those boxes vertically, the voltage is measuring 0.1 millivolt. Again, there's 5 of them from bottom to top, bold line to bold line of the big box. So 0.1 millivolt times 5 is 0.5 millivolt. Okay? If you see here on the left of this strip, the example where the P wave, they're showing you, because that's the first rounded upright round motion, they're showing you that one little box. That P wave is coming off of what we call this isoelectric line here, where the voltage is 0. It's kind of the straight line. That P wave is measuring 0.1 millivolt. Does everybody see and understand that? If you don't, please speak up. Okay.
Will the isoelectric line be the same place on every EKG?
It's not going to be perfectly straight and beautiful like this on every single EKG, no. No. And we'll see some variation here as we start to look through some examples. Okay? All right. So, again, this EKG, the electrical activity, it can be graphed and measured on paper. I talked about that, measuring the time from left to right and measuring the voltage of it from bottom to top. Okay. All right, I gotta watch the time so I don't forget to give you all a break. I kind of get excited and start talking and forget about that. So if it gets to be 10 till and I'm talking and seem oblivious to the time, somebody please just tell me that it's time for a break. Okay. So this picture, if only all of our patients' EKG strips would look this beautiful, this would not be difficult at all. But this is not how it's always going to be. More times than not, it's not going to look like this, unfortunately. Okay, but with our P wave here, everyone sees the P wave on the picture. The P wave is representation of our atrial contraction. So the depolarization, the squeezing of the atria, it's going to send that blood down into the ventricle through that tricuspid valve on the right side and the mitral valve on the left side. That's what the P wave represents. It's the contraction or depolarization of the atria. Now, keep in mind that your right pump, your right side of your heart, and your left pump, the left side of your heart, this is happening simultaneously. It's not like everything goes through the right side and then through the left side. No, it's happening at the same time, okay? So the atria are contracting together, the ventricles are contracting together. Now, the QRS starts with this first negative deflection going down toward the letter Q there, and then up real super high in the sky to the R wave, and then the S. So that is known from that first negative deflection there to the end of the S where it's going back up toward the isoelectric line. That's known as the QR interval. You'll also heard it referred to as the QRS complex. That it doesn't matter, okay? What's happening in the QRS complex here is that's the ventricular contraction or the ventricular depolarization. It's squeezing the right side, the right ventricle, sending all that blood out to the lungs so it can pick up some oxygen. And the left ventricle is squeezing to send all that oxygen-rich blood that it has over to the rest of the body, okay? Now, the T wave, larger than the P typically, that is representation of the ventricular repolarization, resting, recovery. You're going to hear those terms used interchangeably. That is representation of that. That's when the ventricles are refilling, they're resting, and they're getting ready for the next contraction, the next depolarization, okay? So if my atria contracts here with a P wave, my ventricles contract with the QRS, and then my ventricles rest with the T. Don't my atria have to rest as well? Don't they have to repolarize? If they have to repolarize, where is it? Why am I not seeing it? If you know, unmute yourself and tell me.
They can't fill with blood because the ventricles is what's getting filled during diastole.
Well,
So
they're
they
getting,
can't, like,
they're simultaneously getting their blood back from either the left side from the lung or the right side from the body. They're getting more blood. They're not really sitting empty per se. It all happens so fast and simultaneously. But they're refilling. Does anybody else want to take?
When the ventricle
Wouldn't it?
contracts.
I'm sorry.
That's what I was gonna say.
Don't they refill when the ventricle contracts?
Okay.
Yeah, I was going to say something like they're refilling somewhere between the P and the R.
Okay. Well,
Um,
oh, sorry, go ahead. Somebody has something to say?
I had thought maybe because it's following the electrical signal, so you can't necessarily see like atria filling because the electrical signal's not at that point.
Okay. So you're all on the right track. Every one of you are on the right track. So the atria contracts in the P wave, the ventricles contract in the QRS, and the ventricles recover in the T wave. The atria is going to recover, but it is so insignificant on this electrical printout in comparison to the ventricular contraction that we just don't see it. The atria are still repolarizing, they're still filling, they're still resting and getting ready for their next contraction. But when you look at the voltage of this QRS, the recovery of the atria, which are smaller anatomically than the ventricles, It's really just insignificant compared to the depolarization, the contraction of the ventricles that we just don't get to see it. So it's there. We just don't see it. Who has a
Miss
question?
Eden?
Yes.
Why sometimes does the QRS complex go down instead of up on certain EKG strips?
Yeah, so it depends a lot of times on what lead you're looking at. Okay. And we'll see that in some examples. You'll see where some go down and some go
Okay.
upright.
I have a question.
Okay.
Yeah.
So just to sum it all up, the P wave is basically like your contraction, your depolarization. Then the QRS wave is just like the squeezing of the blood going to the lungs into like the systemic tissue. And then the T wave is just the ventricular depolarization because they're relaxing to basically do it all over again.
So you're close. You have a little bit of your terminology mixed up, and it's going to be important that you understand it. So I'll just say it again, okay? Because I'm sure that there's several people that have the same question. So thank you for being vulnerable and asking. Okay. So the P wave is the atria contracting. It's the depolarization. It is going to squeeze and send the blood out. Okay, down into the ventricles. Okay. The QRS is the ventricles contracting. And if it's the right ventricle, the blood is going to the lung to pick up oxygen. If it's the left ventricle, it's contracting and squeezing and sending that oxygen-rich blood out to the rest, out to the rest of the body. Okay? The T wave is the repolarization, resting, recovery state for the ventricles. And it's filling because it already squeezed during the QRS, right? So now it has to rest and let all of that blood come into it and recover and get ready for the next contraction to happen. The
Okay,
P wave that represents the contraction or depolarization of the atria, it also rests. It repolarizes. The atria still has to repolarize. It still has to refill with blood. But it's the voltage of it, the activity of the atria repolarization is so insignificant compared to the depolarization or contraction of the ventricles, which is represented here by the QRS, that we just can't see it. Does that help everyone?
Yes, thank you.
Okay, good. Good. All right. I wish they would all look this beautiful. Not so much. Not so much. We can't get that lucky. We can't get that lucky. All right. So I'm going to start breaking it down. We've talked about some of this a little bit already. The P wave. The SA node, I said, is the heart's pacemaker. Okay? The SA node fires the impulse to depolarize the atria. It's represented by the P wave on the EKG strip. Okay? The atrial depolarization is represented by the P wave on the EKG strip. It represents a stimulated state, a contraction of the atria. Typically, it's rounded and upright, not usually more than 0.3 millivolts high. So 3 little tiny squares within one of those big boxes high, not typically more than that, okay? Now, there are some things that can change the size or the shape of the P wave, such as age, beta blockers, if the atria is enlarged, if the patient has valve disease, okay? Because remember those valves, we have valves coming into our heart, but we also have them between the atria and the ventricles. So some of those things can change the size or the shape of the P wave, but typically we're going to see it nice, rounded, upright, and it's not going to be huge. It should, most times I think you're going to see that it's smaller than the T wave, okay? Now, an absence can mean that the SA node has failed. And we've already talked about our AV node being our backup pacemaker. So we're gonna look at that again as we continue on and look at some strips. Okay. All right. I like this picture. I think I stole it from your book. I can't tell you what page, but I believe I took it from there. So the SA node, everyone should see that there toward the top left of your screen in the green. The SA node is the heart's pacemaker. It's going to fire. The atria are going to contract. That's going to create the P wave on the EKG strip. So you see how the green SA node on the left matches up to the green P wave toward the middle of your screen. SA node fires, the atria squeeze. Then the AV node that sits down there on like the bottom floor of the atria, that's going to slow things down. Remember I said the AV node intentionally slows things down because we want the ventricle to receive all the blood from the atria. That's represented there by that little pause you see in red on about the middle of your screen there on that EKG strip. And then in black, you see where we've got the right and the left bundle branches, the bundle of his, the bundle of branches, and those little finger-like things. Those are your Purkinje fibers, the his Purkinje system. That is represented by the QRS that's in black on the EKG strip. Okay, those feed the ventricles and that ventricular muscle. And that's going to be represented by the QRS. The ventricles are depolarizing, contracting, squeezing, whatever you want to call it. That's what's happening during the QRS. Then the T wave is that light blue color there. That is the ventricles relaxing. We call that repolarization. They're trying just to breathe for a second. It's not even a second. It just happens so fast. Listen to your own heartbeat. You know there's not a full second between it. It's just ever so brief, and those ventricles can receive more blood and get ready for the next contraction, the next depolarization. Hopefully matching the places up in the heart with the EKG strip there helps you a little bit. I will tell you this, you need to know what part of the heart causes what part of the EKG strip, and you need to know, and as we go through the rest of today and tomorrow, you need to know and understand what's wrong with the heart or where the problem is if some of this EKG strip does not look normal. That should be a big hint for your test, okay? It's important that you know what part of the heart it's coming from, what it represents, what it should look like, how big or little it should be. You need to know that, okay? And if you do these, go ahead.
Oops, sorry, I thought you were pausing.
Go ahead.
So when you say what part of the heart, are you talking about like where it's saying like whether it's an inferior, lateral, septal, or anterior lead? Or are you talking about just specifically what's contracting?
Yeah, so good question. So I'm saying like if you see something abnormal on your EKG strip with the P wave, you should be able to tell me that there's a problem with the SA node or something in the atria is gone awry. Okay, because we know the P wave is representation of what's going on in the atria. Okay, now you're gonna have to figure out what it is too, and you're gonna know that after we get done with the lecture today and tomorrow, and hopefully you watched your EKG videos. Okay, if you see something wrong with the QRS, you should know that that's something going on with ventricles. And then you further define what it is. It's not just a memorization like, oh, the P comes from the atria and the SA node and the QRS comes from the ventricles. You need to know the detail. We don't ask, like Dr. Benetti said this morning, we ask very few knowledge-based questions. You have to have the knowledge to make a right decision and to understand, okay? But you do need to know what part of the EKG represents what part of the heart, okay? All right, how am I doing on time?
It's time.
It's time. Thank you. All right, I will see you all back. I've got 12:51 here on my cell phone, it looks like. So let's come back at 1:01 and we're going to plow through a little bit more of this basic understanding. And then tomorrow it's a deep dive, so everyone get great rest tonight. So I'll see you in 10 minutes.
Ms. Stephen, I have a question.
Yes, go ahead.
When you are measuring the voltage of like the QRS,
Yes.
do you measure it from like the bottom of the Q, or do you still measure it from the isoelectric line?
So we're going to get into that a little bit more when we get into looking at some of the dysrhythmias and things like that. But you see on this picture here, like at the bottom of the bottom of the Q. Yeah. So you wouldn't take all of the positive voltage and subtract the negative voltage,
Okay.
if that makes any
Yeah.
sense. You would start with the lowest point. I have sometimes seen people that they measure from here to here. I don't think you're going to really
Okay.
have to worry about that. We're more so, I can't say always and can't say never,
Right.
that's how medicine is. We more so are interested in the time this way. And as I start to move through the rest of this, you're going to see that's what we're mostly interested in, okay? For testing purposes, I don't recall that we have ever asked about the voltage of the
Okay.
QRS, so I wouldn't get super hung up
Okay,
on that,
thank you.
okay? I need to look something. I need to make sure. Okay, I want to make sure my recording was still there. Perfect. Okay. Okay, so I have 101. We are going to continue on, okay? I might have to stop and let somebody back in the waiting room. But okay, so I like this picture again. I think I stole it from your textbook, but I'm sure you can find it online. Lots of good examples too, if this helps you with the colors. Everybody learns a little differently, like I said before, so I think it's good to offer some different, views of things to make it make sense. Okay. Moving right along. There we go. I thought, oh dear, my mouse better not give out on me now. Okay, so the PR interval, you'll see here, I'm not going to read your slide to you, but I do want to mention it's the total time of the atrial depolarization, the atrial contraction, okay? The AV node is the electrical pathway, or gateway, if you will, to the ventricles, and it's going to slow the rate down to ensure, again, that all the blood has had time to move from the atria to the ventricles. We don't oftentimes measure a PQ wave. Really don't even hear people talk about it often, but if we did, that's the time that it takes for the signal to travel from the SA node, we know at the very top, the heart's pacemaker, to the AV node at the bottom of the atria. Again, I rarely have heard it in my practice, but if someone ever says something about the PQ, that's the time it takes to get from the top of the atria, the SA node, to the bottom of the atria, the AV node. Okay, normal, you need to know this. Normal PR interval is 0.12 to 0.20 seconds. Again, when I talked about measuring from left to right, when you're looking at an EKG strip, the small squares within the one larger box, you need to know that the PR interval, again, the total time of atrial depolarization, takes 0.12 to 0.20. Now, we talked about the QRS complex already. The QRS complex is that firing of the AV node. Let's move back in. Okay. It's that firing of the AV node at the bottom of your atria to begin the ventricular depolarization. It begins that ventricular contraction, okay? If there is a Q wave present, sometimes it's not as clear as that example I showed you. Sometimes all you see is the isoelectric line and then it goes up and down. It just looks like a witch's hat and it doesn't have that first little negative deflection. But if a Q is present, it will be less than 0.04, less than one small square, okay, in duration. And it's going to be about, Jenna, this is to your question earlier, about 1/3 of the total voltage of the whole QRS complex. Okay, it's going to be very small compared to the whole overall. Okay, now conditions that could alter or change the size of the QRS complex would be ventricular enlargement, dysrhythmia medications the patient's taking because they know they have a problem, electrical defects. They might have some electrolytes out of order, like they might be hyperkalemic, like their potassium is too high. They might have COPD. Those are all things that could change the size and shape of the QRS complex. Okay? Again, you don't always see that first negative deflection on that Q. Sometimes you just see it go off the isoelectric line, straight up, straight back down, like a witch's hat, or even, sometimes it's even tighter than that. Okay? The QRS really is a spread of electrical impulses through the ventricles, and it's the sum of the ventricular muscle cell depolarization, and that's what triggers the contraction of the ventricular tissue, and then the QRS begins. Okay, I need to say that again.
Yeah, can you repeat that?
Yep, I sure will. So this is representing a spread of electrical impulses that go through the ventricles. It's the sum of the ventricular muscle cell depolarization with contraction. We know depolarization means the contraction. It's triggering the contraction of the ventricle tissue, and then the QRS begins. Okay? Now, notice there on your slide, you need to know this, just like I told you about the P wave. A normal length left to right of a QRS complex is 0.04, so one tiny square, to 0.12. So that's 3 tiny squares, right? Now, I gave you an additional resource there. Sol says it should be 0.06 to 0.10. We're going to go 0.04 to 0.12. That's just to say that you might see a little bit of variation depending on what piece of literature you pick up. But you need to know QRS is 0.04 to 0.12 seconds in length from left to right in order to be considered normal. If it is a wide QRS, wider than 0.12, that indicates there's a conduction problem with the ventricles, because after all, the QRS is representation of the ventricles. Okay. Okay, the QT interval. This interval is the time frame for the ventricular depolarization and repolarization. I already told you the QRS is representation of the ventricular depolarization contraction. We see that big QRS on the strip. I already also told you that the ventricular repolarization, when it rests, it refills, it recovers. That's represented by the T wave. So the QT interval is from the beginning of the QRS complex to the end of the T wave. Now, the slower your heart rate, the longer the QT wave is usually. Okay? And there's an approximation of what it might look like. Okay? We do not use this for rhythm determination. Okay? There are some reasons why you might have a prolonged QT. I already said lower heart rate, hypocalcemia, let me start that over. Lower heart rate, hypocalcemia, so low calcium, low potassium, so hypokalemia. The heart could be ischemic, needs oxygen, right? It could have an infarct. Okay. Now, the QT interval, typically when you're looking at that full 12-lead EKG, the QT interval, a lot of times, is going to be the longest when you look at a V2, 3, or 4. I don't think you really need to know that, but it's helpful information so that you don't think, oh, something's really wrong here. It might just be the lead that you're looking at. gives a little bit of a different representation. Okay. Now, the ST segment, it connects the QRS complex with the T wave. We'll look at some examples. I'll point that out, okay? It is not a wave in and of itself. It's a segment. It's a period of time where you will see the voltage go back to that isoelectric line. It may not be perfectly on it, but it should be evident enough, okay? If we have an ST depression, that could be that the patient's taken some sort of medication for ischemia, okay? Low oxygen to the heart, okay? By itself, it is not measured, okay? If that ST segment is raised up off of the isoelectric line, that is suggestion of a myocardial infarction. Okay, so we hear doctors and nurses talk about STEMIs. That just means a ST elevated myocardial infarction. Now, people can have an NSTEMI, which means that the ST segment is not elevated, at least at that point. Okay, but it's a segment and not a wave. Okay, everybody with me so far? If you're not, unmute yourself and let me know.
When you say that it goes back to the isoelectric, like, so on that picture you showed us, like the S wave kind of like dipped down, then came back up, and then went into the T wave. Is that like where it comes back up, what you're talking about?
Yeah, let me see if I can. That one's just too pretty. I don't think I showed you another one. That one's also too pretty. I'll find one. I'll show you. Yes. On this one though, you see, after you see the S at the very most negative deflection, it's coming up, 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 right where you see it starting to go off to the right, like it's starting to straighten out and go toward the T. That would be your ST. Can you all see my mouse? Okay. So like right in here where it's starting to go to the right, this would be like my ST segment here to about here, because this is coming up off of that isoelectric line. So this piece right here would be my ST segment. Don't start thinking it's clear down here. That's still part of the S wave. It hasn't gotten back up to that isoelectric line yet. Does that help? Okay. All right, so moving on to the T wave. Again, we talked about this. That is the repolarization, the resting, the recovery, the refilling phase of the ventricles. They have just made this huge contraction during the QRS, and now they need to repolarize and recover. Okay? Let me see here. Somebody's got something in the chat. Let me see if I need to address that. Oh, somebody was just sharing a resource. Okay. Okay, so that is representing the repolarization, again, of the ventricles. It's going to follow the QRS complex, okay? When we get into codes, we're going to talk about this more. When we get into simulation, we'll talk about it more. But you never want to shock or defibrillate somebody on the T wave. The ventricles have to recover, okay? So when we get into cardioversion or defibrillating somebody, we want to make sure that there is no electrical firing on the T wave, okay? When we do cardioversion, we will want to shock and do it synchronized cardioversion, because then the machine will know. It will identify where it's appropriate to give an electrical shock, and we want it to fire back in the QRS complex on the R, because that's when the ventricles should be contracting, and so that shock would do just that. We don't want it to be shock or to fire an electrical impulse on the T wave, because those ventricles have to rest. Now, you might see some variations from the nice, beautiful T waves that I've showed you thus far. okay? If you happen to see a flat T wave or almost flat T wave, that could mean that the patient has low magnesium. It also might be indicative of the patient having low potassium, okay? If it's a really super steep pitched, peaked T wave, that could mean that they have high potassium, hyperkalemia, okay? Now, as I mentioned earlier when we were talking about why can't we see the repolarization of the P wave, you know, because it's hidden somewhere in the QRS. If you have a QRS, you have to have a T wave, okay? If you have a QRS, you have to have a T wave. Sometimes people will confuse the T wave with the next P wave, but just be very careful. At the ventricles, that larger portion, those two larger chambers of the heart, if they contracted and you had a QRS, you have to have a T wave. It may not be as beautiful as the ones I've shown you, but it will be there.
Miss Stephen?
Yep.
So does that mean you're more likely to have an absent P wave with a QRS instead of a absent T wave with a QRS?
You mean in the contraction following it?
Mm-hmm.
Yeah, we'll look at some examples where you may not see a P wave, where it might be embedded if it came early in the T wave. But don't mistake, if you only have one little bump after a QRS, don't mistake that for thinking, oh, well, must not have a T wave. That's just the next P wave. I'll show you some examples. But
Thank
yeah,
you.
good question. Good question.
Thank you.
Those ventricles are so big, they have just done massive work. You've got to let them repolarize, and so you're always going to have a T wave. Again, it may not be nice, beautiful like the examples I've showed you so far, but it's going to be there. Okay? All right. Now we're getting into the meat and potatoes. That's all a little bit of review and maybe just touching on a few things that you've never heard or haven't heard in a long time. But now is where you really got to be glued in here, okay? All right, here we go. If I can get my mouse to work, that would be great. Okay, so Dr. Benetti told you earlier today that I was going to teach you the steps in order to identify what the rhythms are, if they're normal, abnormal, that kind of stuff. So step one, you have got to look for a P and a QRS, okay? There should be a P wave before every QRS. You need to see, are they consistent, meaning regular? And a QRS should be followed by a T because, again, the T represents the ventricular repolarization. And if you had a QRS, you have to have a T. So number one, look for a P and a QRS sequence. Okay? Number two, look at that PR interval. Okay? It should be 0.12 to 0.20. Grab something real quick. Okay. Sorry about that. I just wanted to grab another example I'm going to show you guys here in a little bit. And if you have it, you know, that's great. And if you don't, it's okay too. There's lots and lots and lots of resources. Does anybody have an EKG book? Did anybody get one, like an optional book or something that you got from a previous student?
I got the one you suggested.
Okay. Okay.
With the flashcards in the back.
Yeah, some people have that and they found it helpful. We don't require it. Really, everything you need to know comes from this lecture and from your Lewis book. But sometimes, again, people learn a little bit differently. I'm very a visual learner. Some people can learn by just reading and they're fine with that. But I just like to tell you, you know, there's lots of resources and stuff should you want something else. But everything you need to know for understanding and for being successful on the test from that perspective, from EKG perspective, comes from your Lewis and from our lectures. So you don't have to go buy anything else. So don't worry. Don't feel like you're, missing out on something you're not. But again, people just learn differently. And so some people have different books that they're using. Okay.
Sorry, what books are you suggesting? Because someone said I got a book that you suggested, so I didn't hear anything about it.
Maybe it's one of my advisees or somebody that I had in a previous course that asked me. This is the one that I like. You don't have to have it. It's Basic Cardiac Dysrhythmias. This one is by Atwood and Stanton. You don't have to have it. It's something I like to use. You don't have to have it. I use it as a resource. So if somebody asks me, I'll always say, hey, what's on my shelf here? And I'll tell them. I don't have any vested interest in this book. I'm not making money off of it or anything like that. So, but it's just, it's one that I refer to that's on my bookshelf that I like to look at. And yeah, so.
Okay.
But everything you need to know, again, comes from this lecture and comes from your Lewis book. So you do not have to go out and buy anything. You do not have to get on Amazon and spend money. You do not have to do any of that. You will be fine if you fully understand what I'm teaching you and you read your book for additional information. You will be fine. Okay? Okay. Let's see here. So anyhow, step 2 was to check the PR interval. It should be 0.12 to 0.20. Now the PR interval, it's going to represent, the chat box is going crazy. Somebody tell me if I just need to, if I need to address something that's in there, let me know and I'll stop and do that. Otherwise, I'm just going to keep on going through and I can look at it toward the end of our lecture here. But the PR interval, basically, it's going to represent the time that it takes the electrical impulse to be conducted from the atria through the AV node and the impulse to begin in the ventricular depolarization. Okay, so it's measured from the beginning of the P wave. We can look at that again on the line. Okay, to the next deflection from the baseline. So we saw the Q on one of those previous slides start to go down. Let me go back here. So can everybody see my mouse? Okay. So we measured from the beginning of the P wave, so before it leaves the isoelectric line, to the beginning of the negative deflection, so like right in here. That would be the PR interval. And you think, well, the R is up here, and this is actually the Q. Yes, but this is how we measure it, okay? So that's the PR interval. Let me go back to there we go. So it should measure 0.12 to 0.20. Okay, you need to identify, are the PR intervals consistent? Just like we were looking in step 1, do we want to know if the P's are consistent? We need to know if the PRs are consistent. Okay. Step 3, the QRS duration and configuration. We already talked about this when we talked about the QRS a minute ago. The QRS normally is 0.04 to 0.12 seconds, okay? If the Q again is present, it's going to be that first little hook, that first little negative deflection that comes down off that isoelectric line, and then the R is going to be up toward the top at that little peak, and then back down for the S and the negative deflection, okay? Step 4, this is where people get confused, so pay attention. And before somebody asks, yes, you need to know how to calculate all of these methods, okay? There are several different ones on here. You need to identify what is the rate, okay? So it tells you how fast is the heart depolarizing, how fast is it contracting. So the first method is to take 300 divided by the number of boxes, the big boxes, from R to R. That equals your heart rate. The second method is to take 1500 divided by the number of small squares or small boxes within the bigger bold box from the R to R. Now, you see the note there, the little caveat, that will only work if it is a regular rhythm, okay? The third method is, and the easiest, simplest, quickest method really, is to take a 6-second strip, count how many QRS complexes are on that strip, and multiply by 10. Be careful. If you have a strip and it does not have those little hash marks, or you are not told that it is a 6-second strip, you cannot make the assumption that it is 6 seconds long, okay? So be careful. But that is definitely the quickest, easiest way just to calculate a heart rate. The last one, and I'll...
Ms. Teeman?
Yes.
So you just choose one of these ways,
yes,
correct?
But for testing purposes, you need to know them all.
Okay.
Okay. And I'll show you some ways that we can count this out when we look at some of our strip examples here in a little bit. The last one, this usually is the most difficult for the majority of people, but it's very doable. You find an R wave that falls on, well, our examples were red, but so we might have some in here that are black. Falls on the R wave falls on a black line, okay? And count each line 300, 150, 75, 60, 50 until you get to the next R. I'll show you an example. That just sounds totally confusing. I know, I can tell by the look on some of your faces. That's okay. It's probably my least favorite, but it is doable. Don't overthink it. But for testing purposes, you need to know all these. Okay? But the quickest, easiest one's definitely just getting a 6-second strip if you know for sure it is a 6-second strip and going with it.
Steven, I was gonna say about the bottom one. The other way I was taught, like you can count, like if you count from those lines, but for some people it's easier to hear that like it's those boxes. So like how many boxes are between whatever R to R, and like because those lines are all the same. So I don't know if it helps anybody to hear that for that bottom one, but
okay. Okay. So that is step 4, finding the rate. Let me see if I had anything else I wanted to tell you here. I don't think so.
For the
yes.
last one, it says 300, 150, 100, and maybe you said it, I missed it. But is it like, do you count down like 300, 150, or you just count the black lines?
No, as each line would be 300, the next black line would be 150, the next line would be 100, the next one would be 75.
Okay.
I'll show you some examples in a little bit. Okay. I guess like looking at the top one that I have there, like heart rate equals 300 divided by the number of boxes between an R to R interval. So if you counted, let's say 3 large boxes from the first R wave to the second R wave, or even if you did it between the P waves really, but from the R to R, so you get that R to R interval, you would take 300 divided by 3, because that was the number of the boxes, the large boxes, and your rate would be 100. Okay? Now, if you use that same number in the next one, heart rate equals 1500 by the number of small squares, well, we know each big box has 5 small squares in it. And if we counted 3 big boxes from R to R, that would be 15 small squares, right? 3 big boxes times 5 little squares in each box would be 15. So 1500 divided by 15 would still give us a heart rate of 100. Does that make sense? Okay. So that is step number 4.
I have a really quick question.
Yes.
So if we have an irregular rhythm, do we have to do one of the last 2 since we can't do it irregular?
Well, you might keep in mind that You might have a strip and part of it is normal and then it changes. You see it change into something abnormal. So you would have to know, like, okay, do I have a full 6 seconds here of normalcy before it goes into something abnormal that I could actually calculate a rate? A lot of times we have just a 6-second strip. I'm not going to say always, but a lot of times. And so really you can't accurately do that then because, right, your R to R is not consistent and it's not going to be the whole way across. So that's why it's important for you to know all of these, yes. Because again, you can only do some of them if you have a regular rhythm. Okay. Moving on to the next step. Watch the time here. All right, so step number 5. We have to determine, is the rhythm regular or irregular? So if P waves are present, you know it's an atrial rhythm. You know that it came from the SA node because the P represents that the SA node fired, the atria contracted. So then you check the regularity with calipers or paper and pen. You don't have to go by calipers. You don't need to know that, okay? Or you don't have to have those. A lot of times people will just hold up a piece of paper to a grid on their book, or if you're doing one of your weekly math. Now during the test you cannot hold the paper up like this, so don't do it because it will flag you. But like when you're doing your weekly math EKG, sometimes people will hold a paper up and they'll make like a little mark here for something they want to measure and a little mark here. And then you can kind of just figure things out that way. You do not have to have calipers. But you would want to check and see, are things happening regular? You would measure the P to P and the R to R intervals, and hopefully they're regular, okay? But if the marks are off by more than one small box, it is irregular. Not the big box, the small box or the small square, okay? If it is off by more than one small box, it is irregular. Because we know one small box or one small square is 0.04 seconds. That's pretty significant when you're talking about your heart. Now it might be a half, but we're talking about more than one, okay? Okay. Step 6, final step, interpreting the rhythm. So you use the systematic analysis, apply all the rules we talked about, okay? And each rhythm is a definition. It has unique characteristics about it. And that's why they all have their own names. So you have to apply the 6 steps. As Dr. Benetti said, if you've been a nurse a long time, we can maybe look at something and we're like, oh yeah, this is that. Sometimes we have to look and go through the steps a little slowly, in our own head too. It doesn't matter how long you've been nursing. But you need to use these 6 steps. And don't skip them. You're too new at this. Don't skip them because you're going to likely choose the wrong response. Okay? So you're going to learn normal. And once you're able to recognize normal, then we're going to learn the abnormal. Okay? All right, let me just pause for a second and get into the chat box here and see if I need to address anything. Oh, I went backwards on the slide. Sorry about that. I was trying to scroll through the chat box. Like Daisy supplied you all with a reference. Somebody said if you want to rent something, you can. Again, everything you need is in your Lewis and from our lectures, but you're welcome to get additional resources. Your weekly math EKG sheets are going to be fantastic practice for you. Now, I'm going to say that a lot of times students say the weekly strips are hard to read. Do not worry. On the test, they are so much more clear, okay? We've never had anyone say that the strips on the test are hard to read or hard to count. We understand the ones that we use on the weekly math EKG sometimes are a little bit fuzzy or maybe a little bit grainy. Do not stress. The ones on the test will be nice and clear for you. Okay, let's see. Yes, Miss Penny might have tomorrow. I'm reading chat box here. Okay, good. Y'all are helping each other out.
Sorry, one question was how do we measure the strips without paper on the test?
Yeah, so you will be able to see and count the boxes to measure and calculate the time without having to mark it up there. So you'll be able to see that. Okay, I gotta get back to where I was here on the slide. Sorry, I scrolling through the box and I don't want to make anybody dizzy here. The examples on the test are going to be they're going to be clear enough. You're going to be able to count the boxes. Is there, is there 2 big boxes? Is there 3 little squares? You're going to be able to see that clear enough. You're not going to have to hold a paper up there and to measure. Yeah, good question though. Don't stress about that. But as Dr. Benetti and Janie said earlier today, I kind of think about like these EKG questions and the math questions kind of like in basketball, like a foul shot or a free throw. It's just that they should be freebies. If you don't understand this and you don't know how to go through the steps and you don't know how to do this, then you're going to miss a lot of points. But if you practice and practice and practice these EKG strips and your math questions, then when you get to the test, depending on the test, that might be 15 questions you get right or wrong, depending if you know this stuff. So take those weekly math EKG practice tests. They're only like 6 or 7 questions each. Take them seriously. Yes, it does not calculate into your overall grade percentage for the class. You do have to do them. And if you don't do them, we're going to say you have to do them. Now you have to do 2 weeks in a row because you failed to do last week's. But they are going to help you and they are going to ensure that you understand and can identify when your patient is suffering some, some sort of dysrhythmia or some sort of condition. It's important for you to know it, but think about the number of points you potentially or number of questions you potentially lose on a test if you don't know your math and EKG. So please take them seriously. Okay? All right. So go through the 6 steps. First, you're going to learn normal, and then you're going to be able to recognize the abnormal. Okay? All right. We have a little bit of time left, I think. Yeah, we do. Okay, good. Open up the next packet here. All right. So, normal sinus rhythm, or referred to sometimes as sinus rhythm. I'm not going to read the slide to you here, but you need to, again, know those measurements, what your PR interval is, what your QRS is, and you should be able to say, I have 1 P for 1 QRS. That is normal sinus rhythm. There should be 1 P for 1 QRS. Okay? All right. So, now, dysrhythmia means that it's not normal. A lot of times you'll hear dysrhythmia and arrhythmia used interchangeably. Dysrhythmia really is the better term because it talks about irregularities. Arrhythmia really means the absence of or without a rhythm, but you will hear them used interchangeably. And sometimes I slip up and say the opposite of what I really wanted to say. You will hear people use them interchangeably, but dysrhythmia means that it's not normal, and arrhythmia means that it's absent. Okay? You have learned in normal sinus rhythm the only normal rhythm. That is the only thing that's normal. That is the only thing that's going to have the right measurement for a PR. It's the only thing that's going to have the right measurement for a QRS. There's always going to be a P followed by a QRS. There's always going to be a QRS after every P. That is the only normal rhythm. And so now we jump into the really fun stuff and start learning about this dysrhythmia. Okay? So, sinus dysrhythmia, okay? We know that sinus means that it's involving the SA node. Remember, our SA node sits at the very top of the atrium. It is the heart's pacemaker. Dysrhythmia means that there is something wrong. It means that it's irregular, okay? The sinus dysrhythmias that we are going to look at are sinus bradycardia, tachycardia, sinus arrhythmia, I just told you meant absent, and sinus arrest and sinus exit block, okay? So it involves a problem with the SA node. That's why it has the name sinus, but it's something wrong with it, and that's why it's a dysrhythmia. So the first one I had there on that last slide was sinus bradycardia. Again, its first name is sinus, so we expect that the P waves are going to be upright and rounded because we know it came from the atria. It came from the SA node. Regular rhythm, the PR interval is going to be 0.12 to 0.20. Your P to P and your R to Rs are going to be regular. You'll have a normal QRS measuring 0.04 to 0.12. But the last name is bradycardia. So that just tells me that it is slower. We know our normal heart rate is 60 to 100. That's what the SA node delivers to us. So bradycardia is going to mean that it's slower than that. It's less than 60. Okay, so you're going to have a P wave and you're going to have a QRS and everything's going to measure correctly, but the overall rate is going to be slow. Okay, some causes and treatments. You can read the slide there. Sometimes we see this on the monitor when a patient's having a bowel movement, that increased vagal stimulation. But you can sometimes see this, for other reasons too. You can see it during sleeping, especially with athletes. Athletes tend to have a little bit of a lower heart rate to begin with. You have somebody that, is an avid runner or they do triathlons or something like that. They tend to run a little bit low anyhow. But you can see it during sleeping, especially with athletes. You can also see it in patients that have hypothyroidism. Okay. Now, if they're symptomatic, there's medicines and interventions, of course, that we need to take action with there. Symptomatic for bradycardia, some things I'm in particular thinking about is like, are they dizzy? Do they feel cold and clammy? Are they weak? Are they vomiting? Do they have pale skin? Those are some things that you might see with symptomatic sinus bradycardia, okay? And if your patient is not symptomatic, if they are asymptomatic, then you don't intervene. You just continue to monitor. So you might have a question that says, we might give you a strip, for example, on a test, and it might be sinus bradycardia. And we might tell you that the patient has, such and such a symptom. What are you going to do? Or we might say your patient is asymptomatic. When you went to check on them after seeing this on the monitor, you found them asleep in the bed, resting comfortably. What are you going to do? Well, you're going to continue to monitor. If they're asymptomatic, you typically continue to monitor, okay? We're getting you ready for NCLEX exam. And NCLEX wants to know what you, as the nurse, are going to do for this patient with said circumstances. So that's how you're going to be seeing our test. What are you going to do? Or what do you think you need to give? Okay? So, asymptomatic, sinus bradycardic, no treatment, continue to monitor. If they're symptomatic, you might be given one of these medications. Okay, here are some examples. First thing I want to point out before we talk about these. Everybody see at the top of this red EKG strip. Can you see my mouse? These little hash marks. That is what I said earlier is a 3 seconds, and this is 3 seconds. So if you count the big boxes between those, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Okay? That is 3 seconds. And there'll be 15 from here to here as well. I know that this is a 6-second strip because of that. Okay? Now, we talked about measuring. So, see the bold line? Remember we said 1,500 divided by the little tiny squares within the big box, or 300 divided by the number of big squares. Do you remember when I said that on that slide? Let me see. If you're looking through your papers, I'll tell you how many slides back it is. About 10 slides ago. Time flies when you're having fun. It's step 4. So if you're looking through your PowerPoint, if anybody printed that off or whatever, it's step 4 if you're looking through that. Okay. So the first example I had told you about is the heart rate equals 300 divided by the number of boxes from R to R. Okay. And well, that is pretty close to being on the line there. There's an R, and here's an R. So big boxes kind of get blind if you're staring at it too much, right? There's 1, 2, 3, 4, 5, 6, 7. That falls almost perfectly. 8. So who's got out their calculator? 300 divided by 8. What is it?
37.5.
Okay. Now, thank you, Christy. If we've got that with that method. Now, if I just look at this, and I told you in the third example in figuring out the rate was to take a 6-second strip, and we know that this is 6 seconds because this hash mark to this hash mark is 3, and this hash mark to this hash mark is 3. So I know I've got a 6-second strip. So the easiest, quickest way to find out a rate is to count the number of QRS complexes in a 6-second strip. I have 1, 2, 3, 4. So we would say we're roughly 40. Christy said 37.5. That's pretty darn close. Okay. So that's 2 ways of figuring it out. Another way of figuring it out was to take 1,500 divided by the number of small squares between the R to R. Well, we already said there was, what, 8 big boxes between R to R here? And we know that there are 5 tiny squares in each of the big boxes, right? So 5 times 8 would be 40, right? So what is 1,500 divided by 40?
37.5.
Fantastic. We're getting the same thing, aren't we? Now, the last example of how to calculate the rate was to say 300, 150, 75, 60, 50, so on. So on this line here, okay, we're going to say, on the next, we're not going to count that one, we're going to count the next one. 300, I got to back up, I'm like making my eyes go cross. 300, 150, 75, 60, 50, and then you count down to the next R. Oh, my computer's freezing up. Did you all see that? Wait, is it frozen for you guys? You guys okay? You can say, okay, good, good, good. So you would count down like that. We'll have another one that's a little bit better that will help you figure that out. But that's what you basically do. You don't start on this one. You start on the next big line. So we would say 300, 150, 75, 60, 50, 40, 30. That one's a little bit off. They're more than 20. We know that they're more up in this 30, high 30 range. So we'll find another example.
Doing that.
Pardon?
I think you forgot the 100 between.
Oh, did
150
I?
and
Did I?
75.
Oh, for heaven's sakes! Thank you, thank you. See, I get talking and I get excited and I didn't even say it. So okay, yeah, okay. I'm going cross-eyed here. Can y'all see my mouse moving though with it?
Yeah.
Okay.
Miss Steven, I have a question.
Yeah.
I'm probably maybe overthinking this method, but is there a certain number that you like a reason why you skip from 300 to 150? And then is there a method going down from there? Or do you just kind of have to know those numbers?
Yeah, you just have to know those numbers. I particularly don't care for this method. I think it's a little bit, I mean, obviously, like I told you already, the quickest, easiest way to do it is just do the 6-second strip. But if you don't know for sure you have a 6-second strip, you have to default to one of these other ones for sure. I don't really know the reason behind it, but nurses that have been nursing longer, they will almost always use this. You'll hear Janie use this almost all the time. She loves this one, okay? But yeah, let me get back so I don't get blind here again. I have to keep moving in and out so my eyes can adjust. They're old. Okay, so let's try this again. 300, 150, 100, 75, 60, 50, 40, and this is just ever so slightly on the inside of the next big line. So again, based off all of our other 3 methods of calculating the rate, we know that we're somewhere right there in the, mid to high 30s, okay? Maybe 40. So that's a way of calculating out all these. But I wanted you to see this too, like I pointed out at the beginning. I know that this is 3 seconds and this is 3 seconds. So I've got total 6 seconds here. This one, we don't know for sure that it's 6-second strip because we don't have the slashes, okay? But we do know that when we have these bigger boxes, it takes 15 of those to equal 3 seconds, right? Because I already calculated that out for you. It takes 15 big boxes to equal 3 seconds.
I just have a question, like for testing purposes. Like when we first counted it one way, it was 37.5, and then counted it a different way, and it was 40. Like, are we gonna have to answer like open-ended? Or is it just gonna be kind of?
It's gonna be obvious what you need to do. It's not gonna be. We don't have any gotcha kind of trick questions. It's gonna be obvious. It might tell you what method to use to calculate it, though. I'm sorry, did somebody have a question?
Sorry, are we more identifying like the problem with the heart, like the bradycardia? Like, is that more type?
I mean, so if you had this strip, we're going to ask you, what is this?
Okay.
Yeah, and so you're going to have to know. I mean, this one's really crystal clear. It's beautiful. Not beautiful in the sense that they're experiencing a low heart rate, but it's beautiful as that it's very identifiable. You would have to see like, okay, how big is my PR interval? How wide is my QRS? And then you would need to see, is it regular and what rate is it coming? You have to go through all those 6 steps. And how the EKG questions are going to be as far as when you get strips, because you'll notice on your first blueprint, you have, it'll say electrical alterations. And sorry, I'm running over a few minutes. I'll stop here, but I'm going to answer this question. So if anybody has to go, I apologize. It'll be recorded and you'll be able to hear it, but I won't teach anymore today. But you're going to have, like on the first blueprint, I believe it says 10 electrical alteration questions. That's going to be questions about, for an example, like what I said earlier, you see this on the monitor strip. What do you know this indicates your patient might be experiencing, or what would be the best action by the nurse for a patient that has this on the monitor? That's what the electrical alteration questions are, okay? The EKG questions that you see on the first blueprint, test blueprint, and all of the subsequent test blueprints, you see EKG questions outlined on there. Those are actual strips where we say, tell us what this is, okay? And on those questions, you get a drop down. And when you hit that drop down, it might have 20 different things in there, 20 different rhythms, or 20 different possible answers. And you pick the one that identifies a strip. So EKG questions, they're going to be a strip. You tell us what it is. On electrical alterations on test blueprint 1, that means this is what your patient is experiencing. This is what their strip looks like. What might be the best action by the nurse? That's what that means. It's not, in those questions, it's not necessarily identifying what it is. You might have to identify what it is in order to answer the question, but it's not going to be, tell me it's this sinus brady or whatever. Okay. Now this one, you see how I talked about sometimes the T waves may not be nice and beautifully rounded like they are here, but they're still upright, but it's a little more peaked and looks a little bigger, doesn't it? But that's still a T wave. This P wave, it's not quite as beautiful. On this one here, you see where the Q wave is a little bit more of a defined deflection. Well, we have that deflection coming off of this isoelectric line here, and that's Q, but it's a little bit easier to see, whereas this one's a little bit harder to see. You almost can't tell the difference between negative deflection and the upright going to the R, right? It's pretty tight in there. But this seems to be just a little bit wider. But this is sinus brady again. Now, we don't have the hash marks at the top, but we can still count 15 big boxes, right, to calculate this out and figure out how far do we have to go. So here's a big box, here's a big box, here's a big box, here's a big box, big box, big box, big box. And it looks just the same. There's 5 little tiny squares within the big box. Okay, same thing, the voltage is going to be the same. There's not going to be EKG strips that are different in that, oh, this company provided us with 5 little squares by 5 little squares high inside each big box. And this company provided us with 8 wide by 8 high. That's not going to happen. It's going to be, it's going to be the same, in the grids. Okay. We're not going to try and trick you. I mean, that's not the purpose of this. Okay. So we're going to stop there for today. Because I ran over a little bit and I'm sorry, but get off of my screen. There we go. We're going to stop that for today, but if anybody had to leave early or whatever, or if you want to go back and listen to this, so I'll download this to my computer, then I will upload it to our course YouTube page, and I will put the link over onto the class page. How you're going to find that your recorded lectures like this today are going to fall onto your Moodle page is that we will put them under the week in the course that they follow. So this is week 1. So it will take usually from Zoom to download and then upload to our YouTube channel and get over to Moodle. It takes a couple of hours. So later this evening, you will see under week 1, not only have you already seen, watch these videos, EKG, what is it, 2, 1, 3, 4, or whatever. You're going to see, it'll say EKG Part 1 Zoom lecture or something like that, I'll call it. It'll be called the same thing as what your Zoom was today. So today was Part 1 EKG, so I'll probably just call it that same thing. Okay. So then after tomorrow I finish, you're going to see that I upload 2 additional links tomorrow evening, and that'll be our recorded morning session tomorrow. That'll be EKG Part 2, and the afternoon session tomorrow, which will be EKG Part 3. So you'll be able to go back and review these, okay? Does that make sense to everybody? But that's where you're going to find them, okay? Later today, like Dr. Benetti said, a lot of your other things on Moodle are going to open up. Like you guys don't get overwhelmed. I'm here to encourage you. You are going to see a gazillion lectures, and I know you're going to feverishly be like, oh my gosh, I got to get through these. I got to print them off. Okay, pay attention to your calendar. Know what you need to do, when you need to be doing it. Try to stay ahead, and don't let the overwhelming amount of content that's going to open up on the page confuse you and bring about anxiety. I want you to know all your lectures and PowerPoints are going to be at the top. After we record the lectures and we've had the class face-to-face like this, it's going to be, the link will be embedded for you within the week that the lecture happens to organize it the best we can for you. Okay? All right. You guys have a great evening. Try to review this some more. Be ready for tomorrow. We have a really full day tomorrow, but we're going to make it make sense. And I will see you back here at 9, and I'll get this posted as quickly as I can this evening. Okay?
Thank you.
Okay, take care. You're welcome. Okay.